Good afternoon, and welcome to our first hearing of the year. This will be focused on the 2019 House Appropriation Human Resources Subcommittee. It's so good to see all of you again. Many of you come every time, and I appreciate that very much. We do have a couple of new members among us. I'm Katie Dempsey, privileged again to serve as chairman, grateful for that. I'm going to start down here to my far right and let members introduce themselves. We have a few more that may be coming in. There were a couple of quick meetings happening, so we could start with you, Emery. Wait just a minute. Yeah.
Representative Emery Donahue, District 30, Gainesville, Hall County.
Hey everybody, Burt Reeves, District 34 in Cobb County, and very honored to be on this committee. Thank you, Madam Chair.
Thank you.
Thank you, Madam Chair. Vice Chairman Tom Kirby, represented District 114, Loganville.
Press the button. I'm Karen Mathiak, and I'm District 73, Spalding, Henry, and Fayette. Thank you, Madam Chair.
And we are joined by an excellent new budget analyst. Tell everybody just a minute or two about yourself as well. Do you have a microphone right there?
Good afternoon. Thank you, Madam Chair. My name is Michael Polachek, new budget fiscal analyst, policy analyst with the House Budget Research Office, so it's very good to be here. Thank you.
Good to have you here, Michael. We've already been hard at work, and I think we're going to have a very good year building off of Governor Kemp's budget that he's presented with us. Let me say, if there are any members in the audience, you are so welcome to come sit up here if you want to. I know you may be juggling multiple meetings, but you are welcome to be, with us here and participate, because I know this affects each and every one of us in all of our districts. So, I'm not going to go too far away from it because we've got a couple more members coming in. I just asked everyone to sort of introduce themselves because we have a few new members. And let me see if I can. Representative Oliver, can you just make sure? I've got your microphone on, I believe, I think. I do. I don't like that one. Okay. Tommy? Just introduce yourself to everyone that's here, just to make sure. I know you have served with us over the years, but...
I'm Tommy Benton, been on the subcommittee, I think 5 years now. So
grateful to have you. Great. Okay, so we are just getting... Thank you, Patty, and I know in the back we have Dwayne. Excellent. Thank you. Okay, so we will begin, first of all, with Veterans Affairs. As I said, we're focused on the 2019 budget, and let's see. Commissioner Mike Roby will kick us off, I do believe.
Good afternoon. Thank you, Madam Chairman and board members. It's an honor to be with you this afternoon. And with me today, I've got Mr. Dan Holtz, Assistant Commissioner for Memorials, Homes, and our administration. We also have Mr. George Canavaggio, who's the Assistant Commissioner for Field Operations and Appeals. And we also have Mr. Mark Bannister, who's our Director of Field Operations. Although we brought several slides with us that are in your packet, I plan to only hit on some highlights and focus on the 6 slides directly related to the amended FY 2019 budget. Our presentation is based on page 76 of the amended FY 2019 tracking sheet. As shown on slide number 2, Georgia remains the 9th largest state in the nation for known veterans population. However, we are ranked 5th for the amount of federal monies coming into our veterans, with $3.64 billion in earned income tax-free compensation, and pension benefits. Of that total, $2.55 billion was the result of assistance provided by the Georgia Department of Veterans Service. This is a very high return on the investment of state appropriated dollars. We are currently operating 51 field offices across the state to provide no-cost assistance to our veterans with their claims for earned VA and state benefits. Our offices are averaging 15.6 office visits per day. To say the least, our personnel are busy. Our appeals division is averaging around 125 hearings before VA administrative law judges each month. Our Women's Veterans Coordinator is assisting female veterans across the state. Our Training and Development Division has improved the quality of our annual training and is providing individual training opportunities on site at our field offices. On slide number 3, we have listed our two state war veterans homes where we are caring for approximately 380 veterans each day. Both homes are processing an average of 10 applications for admission each day. We continue to experience an almost 1-to-1 ratio of admissions to deaths and discharges, a trend that is consistent to what is happening in community nursing homes across the state and the nation. The renovation project to support the opening of the subacute rehabilitation therapy unit at Millersville home is underway, and the unit should be ready for occupancy in FY 2020. As shown on slide number 4, our 2 state veteran cemeteries are busy and averaging a total of 30 interments each month. We opened Phase 3 expansion to the Millersville Cemetery last October, and we will be using the additional space to good advantage. Now, to talk about why we were here, which is summarized on slide number 5. We started the FY 2019 with a total approved budget of $40,882,769. $23,440,744 of that is state appropriated funds. The funding we received has met our needs for the FY 20 fiscal year, so our budget request to the Governor's Office of Planning and Budget did not contain any request for additional funds or redirection of funds. Consistently, the funding adjustments proposed in the Governor's recommended budget for the remainder of FY 2019 only contain statewide modifications. These changes are depicted on slides 6 through 10. On slide 6, there is a $1,783 adjustment to support our agency's premium, the DOAS self-insurance program. You will note all the adjustments indicated for our fiscal programs are related to the DOAS self-insurance programs. The results in a high state appropriation total in this fiscal program for the remainder of the fiscal year of $1,891,965. On slide number 7, there is a small adjustment of $762 for the cemetery program. This adjustment brings the total to $699,745 in state appropriations. The nursing home program depicted on slide 8 has no adjustments. On the veterans program, it has an adjustment of $7,082, bringing the state appropriations total to $7,655,088. Slide 10 depicts the total of adjustments for the GDVS at $9,627, and the new total for the state appropriations for the agency is $23,050,371. Slides 11 through 13 depict our agency's mission, vision, and values. I encourage each of you to review them at your own leisure. Madam Chairman, at this time, we take any questions, be happy to answer any questions that you may have.
Representative Mathiak, is your button? Is your button?
Oh, I didn't.
No,
I'm
no,
sorry.
an accident. That's okay. Are there any other questions? Just a minute. We're getting, you know how it takes just a second for all these microphones to line up. Just a second. That one. Okay. Let's see if it's working. Try it. Yeah. Great.
Good afternoon.
Good ma'am.
Do you have a waiting list at either the Millersville or Augusta facility, nursing home?
We're processing, ma'am, 10 a day.
Does that mean you have a waiting list?
Yes, ma'am, we do.
And about how many are on the waiting list for either facility?
About 10, ma'am.
Okay. Anytime in the 2 years you've been the new commissioner, am I correct? Is it about 2 years?
3.5. ma'am.
And a half, excuse me.
Yes, ma'am. That's okay.
At any time, have you done an additional or subsequent evaluation to know how much Medicaid money you could pull down for the nursing homes if you accepted Medicaid money?
I'm going to let Dan answer that, ma'am.
We haven't looked at it since we did the fee exercise several years ago. And part of the reason is we have so many of our residents at both homes are receiving VA benefits, which puts them up over the threshold to receive Medicaid. And so the number that we would get out of a Medicaid funding methodology wouldn't be that great. So we just haven't looked at it.
That implies then a policy decision to take middle and upper income veterans instead of low income veterans, but I doubt if that you would say that's your policy.
That's not our policy. We take whoever applies, first come, first serve. But it just so happens that when they come in, one of the first things that happens, probably within a day or two of admission, is we bring them down to our economic support specialist, who reviews what their DD 214 says, what their medical history is, and puts in an application for aid attendance, which in most cases is approved, and that's the benefit then on the VA side that throws them up over the threshold for Medicaid.
Okay, Representative Bentley.
Thank you, Madam Chair. Thank you, Commissioner Roby, for being here. I've enjoyed working with you over years, but you mentioned that you have 51 field offices across the state. I often hear veterans always talk about going to the field office down in Dublin. Is there something Dublin does that the other ones like Americas or Macon don't do? And then my last question is relating to the cemeteries.
Okay.
But I'll let you answer that one
Okay.
first.
No, ma'am. It is at the three VA medical centers, Dublin, Augusta, and Decatur. We do have a field office inside there, a state field office. So what happens lots of times, if they leave the doctor's office, instead of going back to their hometown, they'll stop by there and just say, hey, can you help me with this? Or I want to file for an increase, and they can do that.
Okay.
Yes, ma'am.
Is that the same thing they can do in Americas?
Yes, ma'am, absolutely.
Or Macon?
Yes, ma'am.
Okay.
Yes, ma'am. That's what the 51 field offices.
Right.
And we use a database that we call Vetrospect. You could be from Americas and up here and stop in the Griffin office, and Rob Johnson can say, well, Mr. Roby, we understand you, and this is what John Doe did for you down in Americas. You know, they can see exactly what they did. They
Okay.
can track it. But
And
yes, ma'am.
Okay, very good. I just want to know because
Sure.
folks in Taylor County often always going to Dublin, and oftentimes transportation is an issue, but now I can encourage them to take advantage of what's in Americas or Macon.
Absolutely. Yes, ma'am.
Yeah, and lastly, Madam Chair, if I may, just right quick, the Georgia Veterans Memorial Cemetery, how many cemeteries are there?
2,
Two?
Millersville and Augusta.
That's it? Is any?
Glenville, I'm sorry. War homes are in Millersville and Augusta, but the cemeteries, one's in Glenville, right outside Fort Stewart, and then we have one there at Millersville.
Does it appear that you may need another one in the future?
Well, sure, down the road, yes, ma'am.
Okay. Well, just trying to play a plug for rural Georgia.
Yes, ma'am.
All right, thank you.
Yes, ma'am.
Representative Mathiak.
Thank you, Madam Chair. I'm so glad to have y'all here today. Can you give us an idea, where's the funding for our smaller clinics, like the one that you're getting I don't know how far along it is in Zebulon, for example.
Yes, ma'am.
Can you?
Well, that funding is all from the federal. That's the VA health care side of the house that's funding those clinics.
On the federal side?
Yes, ma'am. Then what
Gotcha.
we do is once we know it's approved, we will come to the General Assembly and say we'd like to put a 2-person office, say in Zebulon,
Gotcha.
and ask for the funds to support that.
Okay, thank you.
Yes, ma'am.
Okay, are there any other questions from the committee members? Is there anything else you'd like to share with us at this point?
No,
Commissioner?
ma'am. We look forward to working with you.
Well, thank you so much.
Thank you, ma'am.
Mm-hmm. Okay, so next we will hear from the Georgia Department of Human Resources, Commissioner Crittenden, and then I believe Director Rawlings will also be a part of that presentation. And I would like to take a moment to remind everybody, too, that at the end, we will have some public comment, and I believe there's sign up right here at the end at some point between speakers if you'd like to come add your name to it. Thank you. Whenever you are ready, Commissioner.
Okay, thank you. Good afternoon, Madam Chair and committee members. Thank you for this opportunity to come before you today to discuss the Governor's amended budget for fiscal year 2019 for the Department of Human Services. My name is Robin Crittenden, and I'm the DHS Commissioner. Members of my executive leadership team are with me today, and Interim Director Tom Rawlings is here with his team to present the Division of Family and Children's Services portion of the Governor's recommendations. The Department of Human Services consists of the divisions of Child Support Services, Aging Services, and Family and Children's Services. Our vision is to build stronger families for a stronger Georgia. With each policy, program, and service we provide, we ask ourselves, does this help build stronger families and, as a result, a stronger Georgia? With that in mind, here's how we will use our resources to accomplish our goals, adhere to the laws governing our programs, and hold ourselves accountable to the public trust. DHS has about $1.7 billion allocated to protect and serve Georgia's vulnerable populations. Accounting for DHS and its attached entities, the total FY 2019 budget allocation is $1.9 billion. Now, to turn to the recommendations that Governor Kemp released January 17th. Overall, for DHS, Governor Kemp is requesting an amended fiscal year 2019 budget of $807.7 million in state funds. This amounts to $10.8 million in additional funds for DHS in the amended fiscal year 2019 budget. This includes common changes or statewide adjustments included in all agency budget requests. I will discuss the DHS budget recommendations, and Interim Director Rawlings will address the DFAC's budget recommendations in a few moments. For the amended fiscal year 2019 budget, Governor Kemp is recommending 2 changes. First, approximately $26,000 for statewide training for the Long-Term Care Ombudsman program. This program seeks to improve the quality of life for seniors and adults with disabilities who live in long-term care facilities, such as nursing homes or personal care homes. The program supports residents' wishes while working to resolve problems and provides advocacy and informal resolution of residents' concerns. Effective October 1, 2019, the federal government will reduce the number of complaint codes from 130 to 60. This training will enable the office to more uniformly record work related to complaints about facilities. The data is reported to both the state and federal governments. The Long-Term Care Ombudsman Office has a total of 51 paid workers and about 62 volunteers that work through nonprofits. Second, $154,000 for enhancements to the trail system, which is the system our residential child care licensing unit uses to record information on facilities, process applications for licensure, and report on-site incidents more efficiently. This funding expands the system's capacity to support the work required by the Federal Family First Prevention Services Act of 2018, or Family First. That completes the DHS portion of the governor's budget recommendations for amended fiscal year 2019. Now, Interim Director Rawlings will speak to you about the DFAC's budget recommendations. We will be glad to answer any of your questions after his presentation. Thank you.
Thank you, Commissioner.
Thank you, Commissioner Crittenden. Chairman Dempsey, members of the committee, I'm glad to be here with you all today. So let's go ahead and get into these recommendations for amended 19. Essentially, there are 3 here. The first one has to do with our efforts to implement Family First. The Governor Kemp has allowed us to ask for $504,000 to really beef up our ability to work with our providers. As you know, many of our group homes are going to have to change their business model. Some of them will become qualified residential treatment providers, and we will be using these funds to help them become accredited to be able to do that work well. There's also almost a policy priority. It's not new money, but it's $808,000 out of our existing funds. We'll move some things around as necessary to make sure that we are trying to help kin, fictive kin, and other available responsible adults in completing the approval steps to become foster parents. We really, of course, we need to boost our ability to do that. And perhaps the biggest request here is a growth of 7.1% in our out-of-home care budget, amounting to about $9.9 million for the amended fiscal year. The out-of-home care budget, of course, pays for children who are in foster care, who are also in group homes and other settings. While the numbers of children in foster care have reduced somewhat since last July or so, after a fairly significant spike over several years, y'all were kind enough in the last year or so to increase the per diem for our foster parents, and so we'll need to adjust our payments out to reflect those additional costs. Let's see, that really is the bulk of our 2019 requests, so I'm happy. Well, I think we're both happy to answer any questions you may have.
Okay, are there any questions from the committee? Okay. Representative Oliver.
Thank you. Chairman Dempsey and you were involved too, attended a recent discussion on the issue of relative per diem care for children in state custody versus foster care, and the gap between what we pay the family members to care for a child and a licensed foster care child is about $10 a day. Is that correct?
It's about 88% of the foster per diem rate. So the I've got to actually scribble it down here for you. Not sure what I do with the foster per diem rates. They vary depending upon the age of the child. They go from about $25 to $29 per day, a little over that based on the age of the child. The relative care subsidies, enhanced relative rate, and subsidized guardianship amounts to between $22 and $23 per day.
When was the last time that the Budget Committee tried to close that gap in any way, since the policy seems to be in favor of family placement rather than foster care placement?
Yeah, Cliff can answer that specifically. I remember when it was done, but I can't remember the details of the timing.
The foster care was increased significantly 2 years ago. We did the relative split over 2 years, $5 of each year. So in this current state fiscal year, we kicked in another $5 increase for the relatives. So the gap now between the foster parent relatives is really more like $3 a day. It's less than it used to be.
I was looking at some other numbers that gave me different information, so I'll follow up with that because what we were operating on was a bigger gap than that, but.
It could have been the date because there were bigger gaps depending upon when you pulled those numbers in the last 2 years.
And if we were to increase to make it more the same rather than different, what would be the dollar cost of a $1 a day increase for family caregivers?
Based on about 7,300 unlicensed relative caregivers, including those who are keeping children for the shorter term and as well as guardianships. For the longer term, we're talking about 2.6 million. I would agree with you that we are making a significant effort, and as Cliff noted, we have made a significant effort to boost our support for relatives because they do help us keep children out of our foster care system, keep them close to the community. I think it's also probably important to note that we also want to encourage some incentive for relative caregivers to actually become licensed foster parents, which represents somewhat of the difference right now.
Thank you. I will follow up with you on understanding the exact numbers of the gap, and we may be raising that again in the 2020 budget. Thank you very much.
Absolutely. Thank you.
Thank you so much. Representative, if you would introduce yourself to the room. We did that a little bit earlier today. I think we had.
Okay. I am Shelley Hutchinson. I am the new representative for House District 107. And to tell you a little bit about me, my first job outside of college was DFACS. And I went back to get my master's degree with a 4E grant. And I've been working with DFACS ever since, so this is 22 years. I was at the DFACS leadership meeting last week at 2 Peachtree, and we were talking about the providers becoming Medicaid providers. And at DFACS, there's approximately 160 or so providers, but only 30 or so of them are Medicaid providers. And we were talking about the difficulty that it takes to become a Medicaid provider, which would be helpful for everyone. They can pull down the Medicaid dollars. But I think it's virtually impossible to become a Medicaid provider these days. So is there anything being discussed about making it easier to become and to maintain the providers that you have?
My understanding is that currently is within, especially when we're talking about the behavioral health providers, that's generally within, to be a Medicaid provider is a DBHDD situation. I believe their policy has somewhat shifted over the years from approving a good number of private core providers to, I think, perhaps also considering the CSBs to be that first tier. From our perspective at DFACS, we certainly need good mental health providers. We always have a need for additional counseling, behavioral health, and developmental disability services for our children.
Okay, so is there any initiative to have the two agencies talk and try to make that process easier, particularly to recruit? Because as a provider, we always have a waiting list. By the time we get to noon, we're completely full when it comes to transporters or any other new referrals. And I see more providers closing the doors than becoming new providers. So I guess my encouragement or my question is there any dialogue between the two agencies or even under the DHS umbrella to make it easier to recruit and maintain the providers that you currently have? I
think I can tell you that since I've been here for 6 months, we've been in a good number of conversations, certainly with DCH, with the Mara Group, which of course is the managed care organization provider.
Also a huge problem, but that's a different discussion.
And as well as DBHCD. So.
Okay, are there any other questions? Let's see. Chairman Benton.
Thank you, Madam Chair. To follow up on Representative Oliver's question about the kindred care, do we give any if they want to become foster parents, do we give any leeway to the fact that they're relatives, or do they have to meet the exact same guidelines that somebody off the street would have to meet to be a foster parent?
No, we certainly, to become simply a relative caregiver, if we don't go through all of the same, they don't have to go through all the same training, et cetera. The difference is that we do, of course, do basic safety checks, some background checks, make sure they're capable of caring for a child, et cetera. But the difference is that when they become licensed foster parents, that we do apply the same standard as we do for any foster home for those caregivers. And of course, it gives the added benefit not only to the family of having that additional per diem, but it also gives a little bit more consistency to the requirements, and we can treat them, the same way we treat other foster parents. But simply to become a relative caregiver is not as complicated a process. We're trying to make it as easy as possible. We've actually increased the number of relative caregivers for our children in care from about 19% a couple of years ago to almost a third of our children now are with relative caregivers.
That was one of the things that when we had a study group that went all over the state, that we talked to the individual grandparents or aunts and uncles and we talked to them about becoming a foster parent, that one of the reasons they didn't do that was because they were afraid of the more scrutiny as far as maybe their house not meeting certain standards. And so I was just wondering if we gave any kind of leeway to these individuals that are wanting to be.
So to become we do have the same standards for all licensed foster parents.
Foster parent, licensed, okay. All right.
But not for the relative caregiver who wants to care for a child, but may not necessarily want to go through the process.
Okay, that's what I was asking. And,
yes, sir.
And they have really made a difference for us on that. Thank you.
Thank you, Mr. Chairman. Representative Howard.
Thank you, Madam Chair. My question is, and this, I think we may have addressed this somewhere along the way in the legislature. When a foster kid, what age does a foster kid have to be to age out and be on their own?
So we have children in our care between 0 and 18, and then when they turn 18, if they have not otherwise found permanency, we offer them the opportunity to stay in our care until they're 21. And actually, they can receive certain benefits such as Medicaid until they're 26. So we do have about 300 children who have, about 700 children, I believe, who have remained in our care between the ages of 18 and 21. Many of these are taking advantage of the ability to go to college, go to technical school. Sometimes, of course, they are there just to learn some life skills, and just the same way my 18-year-old hasn't left the house yet. These young people are still growing up a little bit. So we, between our existing programs and then our new Connected by 21 program, we are really beefing up our services to those youth between the ages of 18 and 21.
So many of the kids are taking advantage of that?
Yes, sir. Many of them do. We also understand that sometimes youth will turn 18 and want to leave foster care, and so we encourage them all to stay, and if they want to leave for a little while and come back, we try to let them come back as well. If they want to leave for 6 months and come back in.
Okay, thank you.
Representative Bentley.
Thank you, Madam Chair. I just want to make a comment. Back in the fall, I had the pleasure of attending a committee hearing that Director Rollins and his staff hosted. So I just want to encourage all our members to please keep a check on your emails because those were some very informative sessions that they held across the state. So thank you, Director Rollins and your team, for coming down to Macon, Georgia. Yes.
Thank you. I don't see any more questions at this time. Is there anything that you or Commissioner Crittenden would like to add at all?
No, thank you. Thank you for the opportunity to come before you today.
Well, thank you. I know this is just a small portion of what we'll be doing when we take a look at the 2020 budget later, but I just want to thank y'all. I know this is work that is hard and challenging and very heartfelt, so thank you.
Thank you.
Okay, next on our agenda, we'll hear from the Department of Behavioral Health and Developmental Disabilities. I believe, oh, I'm sorry, I jumped. I'm sorry, I didn't mean to scare anybody. Georgia Vocational Rehabilitation Agency, Director Sean Casey. We'll stay in order. No, I'm sorry, no. I know I probably need new glasses, okay? And I'll remind everyone that we do have a sign-up sheet up front for public comment later, if anyone would like to make any remarks later. Whenever you are ready, Director.
Yes, ma'am. Madam Chair, members of the subcommittee, good afternoon, and thank you for the opportunity to speak with you today. My name is Sean Casey, and I'm the Executive Director of the Georgia Vocational Rehabilitation Agency. I will be brief today, but before I get into the fiscal year 19 numbers, with new elected officials, new board members or committee members, I do want to spend a quick couple minutes going over GVRA and the 5 programs we do oversee, and I will not take up a lot of your time. If we can go to the next slide. Is there enough? That's it? No, I think we're missing a slide, but I will plow forward. With GVRA, there are 5 programs that we statutorily oversee. The first one is truly our bread and butter, which is the VR program. The VR program, we have 40 offices located throughout the state. And a quick note, last time I presented here, we had some changes within the program itself. And 2 weeks ago, we hired a new director for the VR program under GVRA's umbrella. And I am proud to introduce to you Dr. Christine Fleming, who started actually 7 a.m. at Eggs and Issues that Wednesday morning. I give her credit for getting up that early. Christine comes to us with many years of experience of VR in Georgia. The previous 4 or 5, she was leading VR studies at Auburn University, but saw the light and has now come back to Georgia. And fairly or unfairly, with Christine's reputation, not only within our offices, but with stakeholders throughout the state, in my mind, the bar is set very high with Christine. But in these 40 offices, it is our CRCs, our Certified Rehabilitation Counselors, that are doing the job with our clients. They are the ones helping clients develop individualized plans for employment, identifying vocational development goals, and assist with services like assistive workforce technology or work technology and training. And it is during state fiscal year 2018 in these offices, we served a total of 33,753 clients, thanks to your investment, thanks to the state budget allocation. Next, we have our 2 residential campuses. We have Roosevelt Warm Springs in Meriwether County and also Cave Springs up outside of Rome, Georgia. And I would strongly suggest to any elected official to visit, especially Roosevelt Warm Springs, either in the spring or in the month of December when we have our 2 graduations. And it is at that time you are reminded why you work so hard, why you sacrifice, and you meet these young adults, these young men and women who are graduating with certificates, industry-recognized certificates, and you speak with them, and you get their joy, their excitement, their hope for the future. And then you talk to their parents, and then you really get to understand the great work that is being done at these 2 residential campuses. But I would strongly invite anyone and elected officials to attend one of those graduations. You leave with your heart full and your gas tank full. Now, next, I want to discuss our BEP program, which is the Business Enterprise Program. With this department division, if you will, we have more than 60, basically, vendors statewide. All of them are going to be blind, and they operate small businesses. like the King of Snacks on the Twin Towers, and the balcony at the Twin Towers, the Capitol Snack Shop here on the first floor, also the snack shop on the first floor at CLOB, along with all state and federal buildings, and also operating the kitchens in military bases. I would be remiss if I did not take a quick minute to say thank you to the director of the BEP program, Mr. Charlie Garrett, and the work he has done over the last 3 business days. It is 4 business days ago where a crisis slowly made its way to me. Calling Charlie Garrett, reaching out to him, I said, you have an opportunity to be Superman and help out. And through Charlie's hard work, my fellow co-workers, I'm proud to announce that in the 3 snack shops specifically, on the first floor at CLOB, here at the Capitol, and also King of Snacks at Twin Towers, we will be serving Chick-fil-A breakfast and also Chick-fil-A lunch, an expanded menu, sandwiches, wraps, salads, and so that crisis has now been resolved. I'm not kidding.
Thank you for that.
Yes. Finally, in passing, I do want to mention 2 other programs that do receive no state funding. First, that's the Disability Adjudication Services, which is an entirely federally funded program, headquarters in Stone Mountain, and its mission is to make disability benefit determinations under Social Security guidelines. And then finally, the Georgia Industries for the Blind, GIB, which is a manufacturing and logistics facility. There are 3 locations in state. 75% of the workers will be blind or low vision on the factory floor, and they produce a variety of products, including safety vests, classification folders, and pillows, and serve a significant number of state and federal customers. Next slide, we will actually get into amended fiscal year 2019. Looking at this chart, you can see that for all intents and purposes, our budget is flat. First off with the BEP program, a change of $100. Admin, a change of $3,831. Again, the Disability Adjudication Services and also Georgia Industries for the Blind receive no state funding. And then our VR program, an additional $4,681. Total change, $8,612. That takes our state budget to $22,445,942. Finally, in conclusion, I do want to be proactive, and a question I do receive often, especially during session, is the federal match funds. Again, with the state investment that is given from you to us, we have a 4-to-1 federal match. I'm proud to say that over the years, the amount of money that we send back, or is basically we don't have access to and goes to other states, has decreased. However, the latest numbers we've been able to pull show that we are turning away roughly $22 million. $22 million that ends up going to Alabama, Florida, California, so on, and their VR programs. The question I do ask, the question I am asked often is what additional funds would be needed to access that $22 million roughly, and that number is just a little bit above $5.9 million. We support the governor's recommendation, but again, just being proactive, I'd like to educate everyone on that number and just get to that question before it's asked. And Madam Chair, members of the committee, that is GVRA's presentation, and I'll be more than happy to answer any and all questions.
Representative Mathia.
Thank you, Madam Chair. Can you talk to me a little bit about the transportation? First of all, thank you for all you do.
It's not me, it's the 1,400 coworkers, but yes, I will relay that message.
Well, I'm from Griffin, Georgia, and I have a few people that have used your services. But can you tell me about transportation? Sometimes that seems to be
A stumbling
slow
block.
or lacking. Have we asked for more funding for that specifically?
When it comes to transportation, I will tell you, as you start to leave Metro Atlanta, Savannah, Columbus, Macon, Augusta, that is an issue for a majority of our clients. I will say that Georgia is not unique. Traveling, speaking to the other 50 states, my cohorts, if you will, they also have the problem of transportation. I can tell you that talking to our federal partners, talking to other state VR agencies, if you will, I haven't been presented a solid answer of how to address transportation for individuals with disabilities who live in rural areas to get them to the job and back every single day. That is a major stumbling block, and unfortunately, not to be very direct, we don't have a solution for that, and we are in search along with, I would say, the 49 other states.
Okay, thank you.
Representative Bentley.
Thank you, Madam Chair. Just to add on to Representative Matriarch's question about transportation, could partnering with the local county commissioners in some of these rural counties, because I know like in Taylor where I live, the Board of Commissioners handles all of the contracts with DOT for transportation, those buses that take folks around different doctor's appointments and places. Could that be an option for
Yes, that
to
could
address
be
the
an
transportation
option.
issue?
And I'd be more than happy to speak with you offline about that possibility, yes.
And last question for you. The Georgia Brain and Spinal Trust Fund, is that a part of your division?
We do have someone who represents GVRA who does sit on that board and is active within that committee or council, if you will. But
Well,
it is under our umbrella? No, it is not.
Okay. Well, the trust fund and your organization do great work. My husband suffered a spinal cord injury from a car accident last year, and I learned about you all from the Shepherd Center, and you do amazing work, so I thank you. And definitely the trust fund, whatever we can do to keep that trust fund strong, I'm certainly in favor, because they've been great, so thank you.
Thank you, Representative Bentley. I don't see any other questions on the board. I do want to ask you, though, because the questions have been presented to me about IPSE, our inclusive post-secondary education. Is there an update you could possibly give us?
Update I can
on
give
that?
you with the IPSE program is that I think, Madam Chair, I did make you aware, but just in case, I could be wrong, it wouldn't be the first time or last, is that I want to say fall last year, post our subcommittee meetings we had in September, October, we did make a slight change within GVRA, and I'm very proud to announce that we have Dr. Lee Brinkley Bryan, who is now overseeing transition and the IPSE program. I will tell you also that we did anticipate this question. We did a little digging around, and the total number of students that we are financially supporting is still holding steady at 128. I do apologize. I do remember that committee meeting I misspoke and said 129, but it is 128. I will tell you that we have doubled up also our efforts to strengthen that partnership with the participating schools. And I would point to the fact that actually at Eggs and Issues just a couple weeks ago, my personal guest was Dr. Dan Cremens with the consortium who actually presented at the IPSE subcommittee meeting this past fall. And so we have made some changes in-house to strengthen that program, to oversee it. We have doubled up the efforts to strengthen our partnerships with the providing schools, and the total number of students still participating is at 128.
Well, I thank you for that. It is such an important program. I just want to encourage you to keep finding ways to do more and more students, because I think the need continues to grow.
I agree. Yes, ma'am.
So, thank you. Seeing no further questions, we'll see you again soon on the 2020 budget.
Thank you. Thank you all.
Thank you. Okay, so now the Georgia Department of Behavioral Health and Developmental Disabilities, Commissioner Judy Fitzgerald. Okay, Commissioner Fitzgerald, are you ready?
I'm ready. You guys have been dying to get me up here, so I'm ready.
Great.
Madam Chair, Vice Chair and members of the committee, thank you for the opportunity to be here with you and talk about our amended fiscal year 19 budget this afternoon. Have a few important items that we'd like to be able to share information about. So what I'll do quickly today is just remind you of our give you a snapshot of our total agency budget, and then we'll go very specifically into the amended 19 requests, and then take a few moments to really describe each of those in detail, because I know there have been some questions about each of those. And then if we have a few moments, we'll remind you, as always, about future opportunities and challenges that are on the horizon. But we really, as we start, we always do so with a moment of gratitude. You all have been extremely supportive to us in recent years, partly by virtue of our settlement agreement with the Department of Justice, but partly because I think you've embraced the momentum around many of the right things to do for vulnerable citizens in the state, and we really just want to say thank you, and thanks for the partnership. Mike, it's been great working with you as you step into the role and just making sure that we're in communication about information needed both ways. So with that, we begin. And as I mentioned, yeah, let's go ahead and just show you the total DBHDD FY19 budget, just to remind you, I think really a little bit about the complexity and the reality that a good portion of our community, our budget is anchored in funds for community-based services, but we also do still have a significant element of hospital services. We also have the division of state funds and federal funds. And again, you all have been very generous as we've moved to increase what's available in our communities throughout the states. And we usually show you a trend line with that increase in community support. And we just want to say thank you for that. And then just a reminder about administration as 3% of this large budget. So we do the best we can to put all our dollars into serving people in Georgia. Okay, so that was intended as a reminder. So now we'll talk about our amended 19 changes. So this first one is the DOAS self-insurance. I think y'all are familiar with this. This is the budget adjustments that are applied across all agencies. So with your permission, I'm not going to spend a lot of time on that. The next three items are really those that apply specifically to DBHDD and really are integral to our success moving forward. So you see the three of them right here along with the amounts requested. The first one is the Georgia Apex program at $8.4 million. An item referenced as Medicaid loss offset in the amount of just over $7 million, and then funding for the Administrative Services Organization, the ASO, in the amount of approximately $8.5 million. So I'm going to go into each of these in a little bit of detail to tell you a little bit about what each of these are all about. So the first one, the item that you saw there was the APEX program. And I think we're fortunate that folks have become a little more familiar with APEX as Georgia's effort to bring mental health services into our school settings. This is such an exciting expansion. A decade ago, there was a real resistance to having mental health in our schools, and now we have a waiting list of schools that really would like to have mental health services available. I want to tell you just a little bit about the program so that the funds, that folks understand how the funds are used and what they're helping us to do. So several years ago, we started as a pilot program with three really important goals that I think will resonate for you. One was simply to increase access to mental health services in the schools. The second, to provide early detection so that we didn't have to wait until a youth had serious needs, that we could find that out earlier and intervene as quickly as possible. And then the third goal was really to strengthen the coordination between the schools, mental health providers, and the community, because really when everybody's talking together, that's how we're developing the best programs. Within those three main goals, I do want to say, though, that we did prioritize high-need youth and making sure that when those youth, children and adolescents were observed in the school setting, that we could, as quickly as possible, link them to care right in the school setting. So we prioritize those high-need youth, but a really neat thing about the APEX program is that it's designed to impact the whole culture of the school. So it is partly about youth getting clinical services, just as you would think about it. Can they access individual therapy, family therapy, group therapy? That's really good. But what we also find, because of the flexibility of the APEX program, the counselors that are in the schools can also provide ongoing training to the teachers. They can do mental health awareness events and just do some education and observation and really help folks just to connect to a more positive culture and provide support in ways that are just beyond clinical services. So that always was the design of the program, and where we've been successful, that's been a really big part of why I think principals and superintendents and teachers are saying, we really want to have this kind of program in our school. So as I mentioned, the program started as a pilot in 2015. We understood that there was a readiness in communities throughout the state to bring mental health services into the schools, and so we identified some early schools that would be willing to pilot with us, and we have rocketed forward ever since that time. There was such great interest and need, and as you can see here, the rapid expansion that we've experienced. APEX is now, and this is a snapshot as of today, we have APEX programs in 418 schools in the state. And that is elementary, middle school, and high school. It's a mix throughout the state, serving over 17,000 students. This program has been a remarkable success. And I want to explain just a little bit about what's unique about it. Certainly we developed it as a pilot where there are principals and superintendents that want to bring it into their area. That's necessary in order for the partnership to exist. What they're doing is partnering with a local mental health provider. So the counselors still work for the mental health provider, but they provide the services and the support in the school setting. What's really good about the program, the way that it is that when we give funds to particular when we offer the contracts, what it does is it provides seed money to get started in delivering clinical and other services in the school. Many of these services are billable services. There are other things, so just you can imagine that having a clinical counseling session delivered by a licensed professional is a clinical service. You can bill for that. There might be some other things that go along with that you can't bill for, but the idea is if we can bill for services, then those services become sustainable, and the money that we're seeding then we can use to move to the next school. If the schools can earn and the clinicians that are billing the services can reach a threshold of about 60 or 70% of what they do is billable, then that means we're sort of breaking even. And the goal is that you then take the seed money that the state is investing and you move to the next school. And this program becomes sustainable on its own if you can deliver services through a licensed clinician and keep the program going. That's been part of the amazing success, and really where we're building those partnerships between school folks, talking to mental health provider folks. There's been a really enhanced understanding of what the needs are and how we can be supportive at a community level. So we're really excited about the possibilities and the $8.4 million that's now allocated. That'll be another jump start to reaching more schools, more kids, and really continuing to have a very positive impact on the school culture and kids and families that are in need of services, delivering them right where they are. So the transportation challenge that we're all familiar with really recedes because they can get those services right in the school setting if that's what they choose.
Before you go on to the next topic,
Yes.
we may have a question or two.
Yeah,
about
that'd be
APEX,
great.
If we
Yeah.
could go ahead and do
Be happy
that.
to.
Representative Kirby. Oh, sorry. Gotcha.
Thank you, Madam Chair. Just a quick question, and I have not heard this issue come up in Georgia, but from some contacts in other states, they seem to say every once in a while they run into a conflict between these billable hours and what they're doing with the students, and the drive has more been for the billable hours to get money as opposed to really taking care of the kids. Are we doing things to make sure that's not happening here?
Yeah, thanks. What a great question, because that's so important. If all you're focusing on is make that billable, you're not going to get to the totality of what these kids and families need. And that's part of why the program is built, that if you get to 60 or 70% of what you do that's billable, we believe in order to be successful, there are simply some things that are not billable. Calls you might have to make, other things that you might have to do, support that you might offer, that there simply isn't a way in the infrastructure to bill for that. Never is the intention that it gets to all billable. It's to reach that right threshold so that we can account for the services being delivered, but still have the flexibility to meet the individual needs of a student, a teacher, an administrator, that you're not going to be able to package in a billable way. We're fine with that. We want the schools to feel like they're getting the support that they need.
All right, thank you.
Okay, Representative Bentley.
Thank you, Madam Chair. Commissioner Fitzgerald, for these 418 schools, can you provide me with a list of how many in rural Georgia?
Yes, we have a full listing of where all the schools are.
Okay. Because I'm really curious if any from my district are in that 418 list.
Okay. Yeah, I don't know off the top of my head. I know we're in over 50% of Georgia counties and over 55% of school districts. So we've tried to spread well throughout the state, knowing in some of the rural areas there are challenges, but we absolutely can forward a list of the actual schools.
Thank you.
Be happy to do that.
Representative Hutchinson, just a minute, we'll have you. Yeah.
Hi, Commissioner. Thank you, Madam Chair. The APEX program is phenomenal. The issue we had when it first came out was the contracts were only offered to a handful of CSBs and Tier 2 Plus programs. That was a huge, huge hit to the rural providers who'd spent years and years and years creating relationships with local schools, and then to jump in and say, okay, the APEX providers coming in, there was a lot of rural providers that were hurt financially that way. So my question is, as you expand it, I've heard that more providers would be open to get the contracts. Can you talk a little bit more about that?
Sure, I'd be happy to, and thanks for the question. So it's, important for me to state who DBHDD is and why we would start with the CSBs when we do a pilot, because it is important. We are Georgia's public safety net, and our primary responsibility is for uninsured adults and youth. And the CSBs are, in fact, the main provider, the instrumentality of state government that we can most easily contract with, especially when we're starting a pilot program. So for us, it makes sense while we're looking at what is it we're trying to do, how would we deliver this. So that is always where we start, and that is our commitment to the target population that we serve. That said, you have heard about the rapid growth of this program and success, and we are keenly interested in making it available everywhere possible. And now that we've had an opportunity to make sure we understand about how to deliver transparency and accountability and billable services and understand some of these infrastructure pieces, we are, as new funds come in, contemplating how we would expand. First, we expanded to nonprofits, and then expanding even beyond that to make sure that we have as great a reach as we can. So we are open to that. Again, I want to make the point of starting a pilot in 2015 and now being at 418 schools. That's super fast for everybody in government. What's most important to us is to do it right. But we do hear you loud and clear, and we want to make sure we are everywhere and that we've got partnerships with providers of all kinds to serve kids with all different kinds of needs. So, thank you.
Great. Representative Howard.
Yeah, thank you. My question is, piggybacking off of what Representative Bentley just asked, I would like to get that list as well of schools.
Yes.
How, does a school, do the schools have to request to be a part of this APEX program, or do you distribute this out based on population, or how is it done?
Yeah, it's a really good question. So again, another how we started in 2015 versus now how we've made it up to 418 schools. We've gotten a little bit smarter each time that we try and add new schools to the mix. What we have found is critical is we must have support from the local superintendent. That really ends up being key. The funds are delivered to the mental health provider. Which schools they're going to partner with in the locality really are in coordination between the schools through the superintendent and their folks and the mental health provider, understanding where the need is and where the ability is for any given school to partner to provide this kind of service in the school setting. So it's changed a little bit, and we've gotten more advanced and more sophisticated. We do have a lot of interest and a lot of needs, but the key thing is to make sure that the local school system is all in on a robust partnership. And it's more than just putting counselors in there, right? I mean, part of it is we need the school to commit that they have the space to do it, that they have the space for and the willingness to have confidential files kept, that they have an agreement of the ways in which they'll communicate with parents and families about mental health, since this can be a sensitive subject. And we're really seeing many robust partnerships developing out of new conversations between the school system led by the superintendent and then their local mental health provider. So we put out a statement of need and let folks know that funds are available, and then there are requirements that they would have to meet in order to apply. But each year that goes forward, we're learning more and trying to adjust and really hitting the mark with what it is we're all trying to achieve.
Yeah, okay, thank you.
Okay, and so since I know there's been a request, Commissioner, for a list of those schools, I think that'd be good for the committee. But also, I was curious, and I wouldn't expect you to know this off the top of your head, but about how many students are actually being, served. And you don't need to know that. You can send that with the other information, just to give us an idea, because I think this is such an exciting program and a great place for Governor Kemp to start in some of the work that he wants to do in mental health, and to start here in the early opportunities, I think, that exist in our schools. I think we'll see some great outcomes from it, but as legislators, I know we tend to always kind of look at return on investment, and we want to kind of see how many people are there or where do we need to direct those services. So
yeah, so we have our number up there of 17,000 students served. So okay. That's a good, and counting, right, each day. Hold on, Chris is giving me another number.
Yeah, I'm sorry.
Oh, he wants me to let you know that's 17,766.
That many.
So,
all right, good, good.
I also really want to note that one of the things that we're really proud of, and I think you'll be pleased with how these funds are being used, we're reaching a lot of students where this is their first interface with mental health services. And that's really a big part of what we're trying to get to is folks that haven't had a way to raise their hand or be identified in need of help, that we are actually reaching those folks by being actually in the schools. And about 77% of the services delivered are delivered in the school setting. Again, to overcome this transportation issue or how do folks get to what they need. Services that are delivered outside of the school setting might be because the family might request it. There might be ongoing therapy or other services that then they seek to have in their home or in another setting. So we love that the large percentage of services, though, are being delivered in the school, making it as easy as possible for youth and families to get what they need.
Well, that's good, and I'm sorry I had missed it. I even wrote it down. I'm just processing so much. I think like many of us are right here, so excuse me for being a little bit repetitive. And it sounds like you've got a good plan going forward for sustaining this as long as we are partnering with you to help you sustain it. Would that be the correct interpretation?
Yes, and but I do think I really want to emphasize how we view this money. You help seed new programs that have some ability. This isn't like sometimes grant programs that we have that are going to require the full amount forever. So, I mean, it's our hope that this $8.4 million in the amended really has a life of its own, and annualizing it wouldn't mean annualizing $8.4 million. We hope that you'll continue to support, but as we learn more, we can really say, what does it cost to seed this program? how do they sustain it on their own, and be much more clear about that as this program grows. We're really proud, and thank you for partnering with us for the first couple of years here.
Great, great. Okay, I don't see any other questions on that project.
Okay, great. So the next item on our budget is what we reference as the Medicaid loss offset. And this really has to do with money that's in our hospital system alone. So in DBHDD's 5 state hospitals, there are individuals, we still have individuals with intellectual and developmental disabilities. As you know, over the course of time, by virtue of the settlement agreement and by virtue of community settings becoming available, we continue to reduce the number of individuals with intellectual and developmental disabilities that are in our hospital. That is the good and right thing to do, where individuals are prepared and where a community setting can be built for them. That is absolutely what we want to do. It actually has a fiscal impact for us, though, because we do receive revenue tied to those individuals when they are in the hospital setting. So as those individuals have moved to the community, we actually lose Medicaid funds. Some of those are tied to the individual, but some of the funds that we get for those individuals in our hospital are really support overall hospital operations. So what we find over the course of time is that as that funding has diminished, we still have costs in the hospital. So those individuals go on a waiver, they live successfully in the community, but the Medicaid funds that were supporting hospital costs, operational and otherwise, that diminishment of that, we have felt that every year. This is the first year where DBHDD has been unable to fill the gap between what we've lost and what's still needed to keep the hospital running. So this is the first year now that we've sought to recoup those funds through this offset. Because again, and I just have a few bullets as reminders of our hospital system as a whole. We have 5 state hospitals, plus we have 2 hospital facilities that we've closed, but we are still responsible for the upkeep of those facilities, and we have ongoing fixed costs. You can see I reference here on this slide. Our hospitals, we have 469 hospital buildings that result in 5,000 work orders a month. Our facilities are old, some much older than others. They require constant upkeep and maintenance, so those are critical factors. So it's expensive to run a quality hospital system, but that is what we intend to do. If you recall, we will continue to move individuals with intellectual and developmental disabilities from our hospital in the community when we have a place that they can live successfully. So that process continues. Individuals with intellectual and developmental disability cannot come into our hospital anymore. That's part of the agreement that we signed. So the number of those individuals will continue to decrease. And we're trying to make adjustments here for the offset that we have just by losing that revenue.
Okay, are there any questions? I do see Representative Benton, I believe.
Thank you, Madam Chair. Ms. Fitzgerald, on this, on the hospitals that have closed, what is the future plans of those? Are they going to be demolished, or do we have something?
So those plans, our responsibility is to care for the facilities while they are still considered DBHDD facilities. I know there are conversations so the 2 closed hospitals essentially are Rome and Thomasville, and we've closed a fair portion of Millersville as well. So in some cases, local development authorities have stepped in and taken an interest in exploring what can be done, what's of interest in the local community. So we're...
Could you give us some idea of how much it costs to keep up one of those facilities per year that we're having to budget?
We could. I can't do that right now, but we absolutely could.
All right, thank you.
Yeah, it depends on what the campus looks like, how many buildings there still are, but we absolutely could provide that.
And Chairman Benton, I will tell you too, is, you know, the hospital in Rome, I've seen it as recently as this fall. And it is being maintained, I would say, in a way that only the state could do. The buildings and grounds are in excellent showable condition to make it available to development opportunities that do pass in and out of town to try to look at it and consider it. The prohibitive challenge has been the bond on that particular property that was large and encompassing the whole campus. So there's work going on about it, and the bond is much less than it was 8 years ago. So, you know, but
try to keep them up.
You know, then you would have the empty land. Some of the buildings are really in good condition to repurpose, depending on who might want them to, what the use might be that they're considering. You know, it was something without a doubt that I don't think our state wanted to have to go through. But when you look at the greater picture of it, while it's been so challenging, in many ways, those who struggle with mental health, and particularly developmental disabilities, are seeing much better outcomes in their life by not being in an institution. For the most part, yeah. Okay, Representative Howard.
Thank you. Gracewood, I think, is the last hospital that is still open. I think it's still open. And if it is, how many patients do you still have there?
So we actually have the Gracewood facility, and we have a small skilled nursing facility in Atlanta. At Gracewood, we have 103 individuals that are in the intermediate care facility, and then we have 27 that are in a skilled nursing unit there, 27 individuals. In Atlanta, we also have 27 individuals in a skilled nursing unit. That represents the totality of individuals with intellectual and developmental disabilities that remain in the hospital system.
So is there any plans to move those patients out? Because I think most of those are severe cases, and I'm not sure how that works in a home setting, but there are some folk in my area that are passionate about this, and some of the things they're saying is that those patients, when you put them out into another environment, they end up losing their lives or dying or whatever. So I don't know, maybe you can speak to that and tell us.
I'd be happy to. And what I find is that there are people that are passionate on both sides of this issue, people who passionately believe institutions should be shut down and people should live in the community, and people who are passionate about staying where they are. What I can tell you is that in the settlement agreement with the Department of Justice, what the state agreed to was that every individual who has the capacity to live in the community, it's our responsibility to build that capacity. But it must be true that the community services and support can help sustain that person successfully and allow them to thrive and be healthy in the community. So all those remaining individuals have an individualized plan. They can only move to the community when the community setting is ready. That has to do with a residential provider and the supports and services in the local community that need to be ready in order to serve that person. So how are we doing that? One by one individual is what I can tell you. So again, the state's commitment is to continue to move individuals to build community settings that can serve even the most complex and fragile individuals, but we continue to do that very carefully, and we've built quite a bit of infrastructure in the department, an Office of Health and Wellness that has very robust oversight of some of the most fragile and complex individuals.
We're going to send you a little water because I know we're asking a lot of questions
Thank
here,
you
but
very much.
you know how much everyone cares about all of this too. So it's good to have this conversation now, I think. Representative Bentley.
Thank you.
Commissioner Fitzgerald, are you familiar with Flint River Hospital down in Montezuma? If so, I was curious to know if there was any partnerships with your department with that facility down in Montezuma, Macon County. It was a regular hospital that was converted to a facility for mental health?
Nothing that I can speak to at this moment. I'm sorry.
Okay, that's fine. And lastly, Madam Chair, if I just one last question. I hate to go back, but I just want to go back for a moment to the APAC project. Just, can you reiterate for me, please, you stated that you all put out a statement of need and to all of the schools, and the superintendents have to respond to that if they're interested in having such a program in their school system? Okay.
I'm sorry if I misspoke. So, yeah. Part of, in order to be a successful applicant, the funds go to the mental health provider. That's who receives the contract funds. But yes, initially, but we have some non-CSBs that do provide APEX, that are APEX grantees. The local superintendent, they must have a letter of support from the local superintendent in order to be a successful applicant. Without the support and the commitment from the school, it's not going to be successful.
Okay, got it now. Thank you.
You're welcome.
Okay, I don't see any other questions on that topic. If you'd like to continue.
Okay, excellent, great. So the third item on our amended 19 request is for funds for the Administrative Services Organization. And you see our partner in this is Beacon Health Options. And I thought I would take a minute and just remind you a little bit about what an ASO is and what it's doing for us. When Commissioner Berry and I first came into the department in 2012, the department had a number of vendor contracts that had been patchworked together year after year, as we often do. Keep it going. But when we first came in the door, we were told really this patchwork and year-to-year extension was probably not the best way to really manage the large-scale service delivery system that we have. So we spent a year really in planning for pulling all of those contracts into one efficient and coordinated contract and having a single vendor. We did a very large RFP, the largest one DBHDD will ever do, and Beacon Health Options actually won that award. And since that time, so since 2013, they have partnered with us, and I really want to say to achieve the goals that you see here. The idea is ultimately to deliver more efficient and coordinated care and to have a managed system of authorizing care, paying claims, and having an eye toward improving quality all along the way. That is a very complex and large undertaking. And we built alongside with Beacon, the idea was you don't build that overnight. The functionality of this, of the ASO has increased over the years, and this phasing in was planned so that we could modernize the way that we do business at DBHDD. And I think it's important maybe just to think about this. We are a large-scale healthcare service delivery system. We have a network of over 700 providers that deliver all different kinds of services. The more that we can say back to you that the state funds that you give us, that we can be transparent and accountable for what services are being delivered, what you're paying for essentially, and then really ultimately being able to say, are people getting better? I mean, that's the question we all want to know. As a result, count services delivered, but ultimately, we really want to say we're delivering quality services in a system that's reliable. So that's what the overall goal is. We did not have the technological infrastructure to build that ourselves. So Beacon has been a really good partner in building something that's unique to Georgia. Because we did not want an off-the-shelf solution, because Georgia has some quirks in the way we do business, some of which quirks need to be corrected and get us into the modern era. Other things, really, it made sense to adapt to, here's how business is in Georgia. So all of that to say, the Administrative Services Organization is a vital part of how we, as a large health system, deliver services and provide accountable services so you know where the money goes. We can all make a commitment to seeing quality and transparency in that service delivery system. So, and really one of the other goals when we first set out to do this was to begin to integrate our system, you all know we have behavioral health services, that's mental health and substance abuse, and then we have services for individuals with intellectual and developmental disabilities. But you know what the reality is? Sometimes individuals in our state have both of those disabilities, and we can no longer silo. So the more we move towards having a data system that says, how do we serve the individual, and how do we have a set of information that's about the individual, and move towards serving that individual and family needs. So the more our system is integrated, and the more we can build and grow and have a modern healthcare accountability system, that's what the ASO has always been about. So I want to flip to the next slide because it just gives you a little sense of some of the functionality and also the scope of what the ASO is doing. So many of you, I hope you are familiar with GCAL, the Georgia Crisis and Access Line. This is our 1-800 number. That's 24/7, 365 days a year. You can call this number in crisis, or you can call it just to say, hey, I'd like to have a mental health appointment. Where would I go in my local community? What you can see here, so GCAL is one of the functions of the ASO. So I want to make that connection for everybody. And you can see here a little bit, I want to make sure y'all are aware of the volume of services that is happening through GCAL. So you can see these annual numbers of 250,000 inbound calls of any kind, 160,000 outbound calls. So some people call in, question answered, linkage made. Some of the calls that come in require a lot more coordination and linkage with partners in the community. So those are the outbound calls. And then what is also critical, you should know that GCAL also dispatches mobile crisis. And again, I talked to many of my fellow commissioners. Not many other states have mobile crisis available statewide. And we do for mental health crisis and individuals who have intellectual and developmental disability and are in crisis. So GCAL is the point. They have licensed clinicians to do phone consult and really talk through with the local crisis in the community and to make a determination, should our mobile crisis teams be sent on the ground to help resolve that issue that's come to their attention. So 16,000 mobile crisis dispatches annually. So you can see the volume, I think, of what they're fielding. Another function of the ASO you can see is provider enrollment. So again, another annual figure of 980 new submissions. And I should say these could be all different kinds of things. Could be a new provider, or it could be if a new provider wants to open up another site, they actually have to enroll, and we just have to make sure that site is serving the needs and meeting basic standards that we all want to agree to in this state. Another function of the ASO is to authorize intensive services. And I want to say a word about this, hopefully not get too confusing, but what the idea in most of healthcare is for regular and ordinary services to just go ahead. You don't need special permission to do that, right? Just like in your own healthcare. You want to get a flu shot? Great, we do it. Nobody needs special permission. But if you want to have a knee replacement, right, then that has to be an authorized service. It's the same in behavioral health, for instance. So if you were going to get routine outpatient mental health counseling, you might be readily authorized to do that. If you're at the highest end of our need, we might want to authorize and make sure the funds we're spending for very expensive high-end services, that those are authorized, and we're keeping a careful eye on utilization of those services. That's our way to say back to you, the dollars that you give us, we can be accountable for those. So we do have an authorization process for intensive services. And then when services are delivered, there's a claim, and then that's what we use to pay the provider and say, we see that you delivered this service, here's the payment. So it's an ongoing, as you can see, processed 816,000 claims in a year. So this is an ongoing process of services being delivered, accountability being determined that actually the service was delivered, and then it's in your quality setting that you say, and are people getting better? So the last functionality item there, as you see, are training of providers and quality reviews, where a team goes on site to really take a deeper look at what's being delivered and what's, that we can make sure that quality and compliance standards are being met. So that's a pretty high-level overview of what's a complex system, but we did want to share some of the functions and give you a sense of the volume of what's being delivered through this important partnership.
We do have one question.
Okay.
Representative Hutchinson.
Thank you. I have a couple of questions. GCAL, I have to say, I love GCAL. And when it was first rolled out, we had it on every treatment plan. The community and schools were giving out notices and posters and cards, but in the last year or so, we're getting mixed messages. And what we've been told is that the only people who can call my GCAL, the crisis line, were clients who were indigent. That otherwise we had to determine who covered them, like AmeriGroup, WellCare, and we had to call their crisis teams. So I think the community is still getting those mixed messages. On one hand, they're getting the number to call GCAL if there's a crisis, but lately, when they call, they're getting the message to call whoever's covering the client in crisis. So what that results in is if you have a child in crisis in a school, that leaves the school responsible to figure out what their insurance coverage is, find out what that number is, call them for crisis intervention. So I would like to get some more clarification about the crisis line and who's getting these services. I also wanted to clarify, Beacon is doing new provider enrollment? Are they in charge of that now?
The ASO is.
Yes,
yeah.
okay.
Mm-hmm.
And are they doing training? I know firsthand they do a lot of auditing, but they've told us that they don't do training anymore.
Okay, so they are a training partner of ours, let me say that. So I think in partnership with DBHDD, as we have learnings from quality reviews, we see them as a shared partner in this work, absolutely. I really want to talk a little bit about your concern about youth in crisis. So let me make sure that it's clear. The GCAL, the crisis line, is for crisis. And absolutely, if there is a call of a youth or an adult, right, there's no age limit on calling GCAL, we want to address that crisis immediately. That is the purpose of having a crisis line. Now, you raise a really important concern. I think that is a challenge for us, right? Again, DBHDD's prime responsibility is to serve uninsured individuals, adults and children. And it is true that if a youth has a payer source, and that payer source has a responsibility to serve that individual in crisis, we would like as quickly as possible to make sure that the responsible party is addressing the needs of that youth. Because if they don't, right, then we're using state funds to pay for something that has already been paid for. I feel an obligation around that. First and foremost, I want you to hear loud and clear, is response, absolutely, to a youth or individual in crisis in any way. But we do feel like it's incumbent upon the state to question whether we're a safety net for an insurer that's not fulfilling what their requirement is in the state. So it's a fine line. I would never want to hear that a youth in crisis got turned away, but I also want to let you know every time we use state dollars to provide services to someone who has insurance, it's maybe a bed that gets taken up when the next kid that doesn't have an insurer comes along. That doesn't seem fair either. So first and foremost, we'll try and meet the need, but if you hear some sensitivity around where there are insured youth and adults, their insurers really ought to be fulfilling their responsibility to provide a full continuum of care.
Question. So is there any way we can go back to fully funding my GCAL to serve everyone? Like, for example, take the money out of, I know this is not a popular question, but if we can take money for crisis response and put it all back in GCAL so that's one central location for, and not have to figure out what child is covered by whom. I thought that was a much more efficient program than going back to AmeriGroup or whoever they're covered by.
Thank you for the question. I think that's, you raise an interesting point. I'm not in a position to say that whether or not that's how it should go. What I think we share is a passion about kids who are in crisis or have needs. We want to make sure they get what they need.
Yeah. Thank you. Representative Henson.
Oh.
Thank you. And I don't know if this crosses over into this or not. I know at one time that we were using our sheriffs to transport people. Are we still, or has this now been picked up in a different area?
So, no, thank you for the question. Like you, in the back of a sheriff's car is not where I want a person in psychiatric crisis to be, but in fact, the sheriffs still do retain the responsibility for transporting when necessary to the nearest local emergency receiving. We're trying to make it as easy as possible. And y'all have heard me talk about our behavioral health crisis centers, why people like them so much. They're closer, there's more of them, excuse me, and it's easier drop off for individuals. So making that readily available is what we're trying to do.
Okay, oh, wait, just a minute. We'll put you back on. What is she thinking?
Oh, I got it. Thank you, though. Okay. Thank you. Does that mean I'm going to be up here a while?
I don't think so. I don't think so. We'd have to take a break then if we did that. No, I think we're coming down to the closing. I do not see any more questions from the committee right now, so if you're ready to wrap it up,
Okay, I am, and I'll just leave you. We'd like to let you know the same questions you're asking, we're asking about both opportunities and challenges ahead. So we'll keep coming back to you. I think many of the enhancements and the things that you're interested in, we're interested too. Core outpatient services, housing, more crisis services. Happy to talk again about the planning list for individuals with DD. We are interested in provider rates. We are dependent on a network of high-quality providers, so those rates need to be adequate. We will continue to talk about addictive disease and the need for more capacity there. Forensic services are our folks involved with the court. That's a growing area of business. And I feel like I cannot talk about behavioral health and IDD without talking about workforce, which remains a challenge. But you all know that, and you've been so responsive to our concerns there. I really want to thank you for your continued support.
We've got one more question. Oh, just lit up. Chairman Benton.
Thank you, Madam Chair. Commissioner Fitzgerald, I had a question. It's not part of this presentation, but it was part of the presentation you did last week, where the number of waivers was increased, I think, by 125.
Yes, sir.
For now in comp. I'm looking at a list here that says we got pretty close to 6,000 people on the waiting list.
Correct.
That's pretty close. And I know that the comp waivers are a good deal more expensive than the now waivers. Are we required to do both kinds of waivers every year, or can we just do one kind of waiver every other year? In other words, we do now, next year we do comp the year after, because it would seem that we would get more bang for our buck with the now waivers to get people off the list, because I think there's probably a lot of people that are never going to get off this list because they keep being supplanted by people that maybe are in worse shape than they are but got on the list late or were added to the list late. Are we required to do both now and comp waivers every year?
Yes, I think we are, but I've never been asked the question that way before, so I'm going to have to double check and say, is that technically true?
But if you could do 4 now waivers for what you do 1 comp waiver for, and that would take 4 people off rather than 1 person off, am I making sense?
Oh, you are, and I think it's a great tension. that exists in the community right now, right? Because high-need individuals, we have spent a lot of time, energy, and resources on individuals who are in our hospital system who generally have come into the community on a comp waiver.
Mm-hmm.
And folks have said, well, gosh, couldn't I serve 100 folks from, who are going to receive the now waiver? But the practical reality is the planning list that exists has some individuals that need the comp waiver and some that need the now waiver. They're not just coming from the hospital, and they have the greatest need, and we don't have another solution for individuals that might need the comp waiver. So imagine an adult with an intellectual and developmental disability who's been living in the community and their parent dies, and they are at a certain level of need and they need the comp waiver. We couldn't say no because we're only doing now waivers right now, if that makes sense. But I hear what you're saying about you can serve more people with, generally speaking, with the now waivers. That's accurate.
So we're kind of stuck in doing some for each, rather than maybe one year doing all for one and then the next year doing all for the other.
I think that folks that have family members that would be eligible for the comp waiver would want us to proceed thoughtfully as we try to with the now waiver as well.
But they would eventually get that waiver.
I'm sorry?
They would eventually get that waiver. It would just be 1 year later.
Possibly. Yeah, so again, just to be, the list is fluid, adapted by need. So if somebody's need increases, they would move up the list.
Okay, thank you.
Yeah, thank you.
Thank you. Okay, I don't see any other questions now. Thank you so much for all that you're doing. I know this was kind of a unique time. Usually for our hearings, I don't necessarily open up the questions either for members that are not on the committee. But because we have some new people, I wanted them to have the opportunity to ask those. But there are constant opportunities to talk to the committee members or to reach out to also to our commissioners and try to find out more. I know that you spoke the longest and the most because this touches each and every community the most, I do believe. So thank you for your work.
Well, thank you, and we appreciate the opportunity to be transparent. We want you to know what we're doing and why, and appreciate the questions back, so thank you.
Thank you. Well, we will move into our public comment time, and right now I only have one person signed up. I don't know if there was anyone else that wanted to speak that didn't have the opportunity to sign up, but the only person on the list is Melanie McNeil, our Ombudsman. We'd love to hear from you. When you are ready.
Madam Chair, members of the committee, and House Budget staff, thank you for the opportunity to make a public comment. Appreciate the opportunity. What I've provided for you is a handout about the amended 19 budget line item number 28.9.2. That's funding for training to comply with new federal regulations for the long-term care ombudsman program. It's a really small budget request, $26,423 that's in the governor's budget. I'm asking you just to keep it in there. It's a small request with a big impact. I did a back of the envelope estimation, and it looks like about 42% of our ombudsman representatives have been with us 5 years or more. 29%, I think, more than 10. And so for us to retrain from using 130, approximately 130, actually I think it's 131 complaint codes down to 60 is kind of a big deal for us. And we want to be as accurate as we can be as we're describing the complaints we get. So in the past year, we had 4,233 complaints from long-term care residents, some of them in nursing homes, some in personal care homes or assisted living communities, even community living arrangements. So it's really important, so I'm just asking, my very brief testimony, just asking that you be sure to keep that money in the amended budget. The change takes effect October 1st. I think we're probably going to need more than what we can get in the amended budget. So looking forward, if you could also include that $26,423 in the 2020 budget, that would be really helpful. I think it's going to take us a while to teach our old dogs some new tricks as it comes to doing our complaint work, and it's really important work. So thank you for the opportunity to ask you to support that.
Thank you. I see one question here, Representative Henson.
Thank you, and thanks for all the work you've done over the years. I just had a constituent ask me a question yesterday. Apparently, she's a nurse. I don't know if she's under visiting nurses or in what respect. But what about, or who does a nurse report to if a patient is abusive to the nurses or the caregivers?
In a nursing home?
No, not in a nursing home. Nursing home's set up with all its procedures outside. Is there anywhere?
Well, I suppose if they feel like it was a crime, so if they were battered, they would just report to law enforcement. For people that are not in long-term care facilities that may have issues, you know, concerns that prompt them to act out, there is also a disability ombudsman who's available to help people in the community. So if they have a disability of some kind that's prompting them to take these actions that, you know, aren't good, they can call the disability ombudsman who could help then maybe talk about, you know, what is their case manager doing to help them, or how might they talk with that healthcare provider about better ways to interact with that person who is reacting to them in a way that's harming them.
Thank you.
Okay, I don't see any other questions. If you wanted to make a public comment and didn't sign up, if you just raise your hand. Okay, I don't see any. Well, thank y'all for your attention. We will be working on this budget and then get ready for the 2020 for some more hearings. I thank you for your interest and participation in making it a priority. This will conclude today's meeting, and we are adjourned.